So my name is Novia Wong. I'm from University of California, Irvine, and I will be moderating this session. We have 7 posters in total today, and uh, one of the authors could not attend, but I will be playing their recording. So just a couple housekeeping items. Every presenter will have about 2 minutes to present, and then we can take a few questions before we have to move on to the next one. If anyone has any questions, feel free to utilize the chat as well as just unmute and speak up. And I will make sure that the presenter will have the ability to share screen. If you can't, please do let me know. So that said, I'm very much excited about the presentations we have today. And just a reminder for those who might be looking for a room that they're, or a specific track, this is the Children, Adolescents, and Young Adults B, track number 3. Okay, so to start us off, we have Heather talking about self-reported symptom severity and attitudes towards mental health apps.
Hi all, thanks so much, Novia. Just making sure I can share my screen here. Okay, can you see it? Okay, awesome. So I only have a couple minutes, so I'll just jump right in. So the purpose of this poster was to look a little bit more at attitudes toward treatment seeking, specifically as it relates to mental health apps. There is a lot of literature out there already about treatment seeking as it relates to in-person therapy and other modalities, but not as much for mental health apps. So just sort of starting to get into that a bit. This study was done with all college students, so about 250 of them who were enrolled to take some surveys, to use an app for a few weeks, and then take a few more surveys. So all of this data is based on their time 1, which was before they actually used the app. So sort of their expectations of what the app would be like. And they also answered just some questions about their depressive and anxiety symptoms as measured by 2 different two different PROMIS measures. So their attitudes toward mental health apps were measured by the APOI. We used 2 specific subscales for this project. One was skepticism and perception of risk, which is sort of just the idea of like, how like comfortable are you from like a risk-based perspective with like the idea of mental health apps. For example, one of the questions that they would answer or rate their agreement with was by using a mental health app, I do not expect long-term effectiveness. Another one was a mental health app could increase isolation or loneliness. So they were rating their agreement with that. The other subscale we used was confidence and effectiveness, which an example of that was, I have the feeling that a mental health app could help me, or I believe that the concept of mental health apps makes sense. So we looked at people who answered those questions as well as filled out their PROMIS measures for depression and anxiety, and found, interestingly, that both depression and anxiety were related, though the effect was small, to attitudes toward mental health apps, but in different ways. So people with higher depressive symptoms based on the PROMIS seem to have more agreement with the skepticism and risk perception statements. So it seemed to be maybe a little bit less open to the idea of mental health apps just based on having some higher skepticism there. Conversely, people who rated their anxiety levels higher rated a higher confidence and effectiveness in mental health apps. And then for sort of the opposite, so depression and confidence and effectiveness, we didn't find any effects. Similarly, for anxiety and the skepticism or risk perception, we did not find any significant effects. So just sort of some interesting findings here, not entirely sure where it's going to head, but we do have some interesting ideas just around if there's anything to do with like negative attention biases in here that may be more at play in depression. There also is some recent literature from COVID-19 studies that show that in general, people with higher anxiety might be like more prone to treatment seeking. So kind of an open question still here, but just some interesting findings on our way to understanding, why people might consider engaging with mental health apps and what sort of patients we might consider offering these sort of interventions to, depending on kind of what they're experiencing and what symptoms they're enduring. So I will stop there.
Thank you, Heather. We have a little bit of time to take some questions, especially since the next presenter is going to be shown via a recording. So any question for Heather?
I have a quick question. Hi, Heather. Thanks for your presentation. Were the outcomes, like the confidence and the skepticism, were any of them related to different demographic variables?
That's a great question. We did not look at that in this. We did have a pretty diverse sample, so I do think it's something we could investigate for the purposes of this study. We didn't, but it is something that we're looking into. We're also, one of the challenges with this specific data is we did change our demographics questionnaire like halfway through to be a lot more expansive and representative. So this data, the data that has already been cleaned and handled was with the old demographics questionnaire, which was a lot more narrow and didn't give us as much information. So I am hoping to run those sorts of analyses once we finish data collection with the next set, now that we have our much more like expansive questionnaire applied, because I think it'll give us a lot better insight. Whereas the one we had before was just a little bit too basic, I felt, to get nuanced in those questions.
Thank you.
Yeah, of course. Thank you.
Anyone else who has questions for Heather? All right, you can always reach out to Heather over chat on Zoom, or if Heather feels comfortable, maybe through contact information like email. For now, let's go ahead and move on to our next presentation, which is by Emma-Leigh Senyard, Understanding Adolescents' Perceived Barriers to Engagement in Online CBT Programs for Anxiety and Their Ideas for Enhancing User Experience. Whew. Okay, long title. Right. Actually, give me 1 second. I just need to make sure I'm also sharing our sound. Okay. All right.
Hi, I'm
Can everybody hear that? I'll play a little bit more.
Emma-Leigh Senyard from the University of Southern Queensland in Ipswich.
Or if I could just get a quick confirmation in the chat to see if you could hear that and see that. Okay, perfect. Thank you. All right.
The University of Southern Queensland in Ipswich, Australia, presenting our research on understanding adolescents' perceived barriers to engagement in online cognitive behavioural therapy programs for anxiety and their ideas for enhancing user experience. Engagement for adolescents in ICBT programs is poor, and we don't really understand why, especially not from the viewpoint of adolescents themselves. This is a problem because higher engagement in these programs is associated with better treatment outcomes. In our study, we interviewed 14 adolescents who had participated in Brave Self-Help, an online cognitive behavioural program for anxiety. We asked them about their ideas for enhancing engagement and what the barriers to engagement might be. We used thematic analysis, and we found that in terms of barriers to engagement, stigma, program factors, such as the design of the program, and environmental factors like distractions in the environment and competing priorities were all barriers. In terms of enhancing engagement, adolescents spoke about program factors such as different types of positive reinforcement and also personalizing the program to their unique needs. Adolescents also spoke about support factors, such as a variety of reminders provided and having optional support, whether that be through email or phone. So overall, our study really highlighted the importance of co-design with adolescents, not just at the design stage of these programs, but also during implementation as well. It also highlighted the potential for the use of persuasive design strategies such as personalization and gamification. We also really need to identify poor engagers early in the program so that we can provide additional support then. Thank you for having us and allowing us to present this research.
Okay, and that was Emma-Leigh's presentation. If anyone would like to reach out to her and her team, her contact information is listed here on the poster. It's emma-leigh.senyard@unisq.edu.au. You can also find the recording on OSF. Okay, so we have our next presenter, Katherine. Katherine will be talking about usage and retention in a smartphone-based mental health intervention for K-12 students, Neolth proof of concept study. Take it away, Katherine.
Hi, everyone. Are you able to see my screen okay?
Yes, we can.
Okay, fantastic. Hi, everyone. My name is Dr. Katherine Grill. I am the CEO of Neolth, and today I'll be presenting research that Neolth completed in partnership with the University of Miami, assessing the implementation of our mental health app in K-12 schools with students aged 11 to 18. So the Neolth app is something that was co-developed in partnership with teens. The way that it works is the app matches each teen to personalized guided activities based on their mental health needs. So those could be guided activities like breathing exercises, creative art, and even videos from real teens about their lived experiences. Teachers introduced Neolth in the classroom setting, and we assessed real-world usage patterns during the academic year. The average age of students in this study was 15, and the majority of students identified as male and as a racial or ethnic minority. We found a 30-day retention rate of 82%, with more than half of students logging in 30 or more times. Stress level, as measured with the PSS-4, decreased 32% across 6 weeks. In 20 cases, Neolth's NLP system for crisis monitoring identified at-risk students. A quarter of these cases were due to relationship issues like bullying. Schools were notified within 30 minutes. So in summary, we found a high level of sustained engagement that could be due to our youth co-design or to the involvement of school staff in the rollout. We found that integrating a crisis monitoring system into a mental health mobile app was a feasible way to escalate students to clinical care. More details about this study will be published in a full manuscript. Thank you.
Thank you. That was very interesting. I know I personally have a couple of questions, but anybody else has questions? Okay, it looks like we got a question on chat. So Hannah's asking, can you talk a bit about the code design with youth that you did? That retention rate is so high.
Thank you. There's a lot more on neolth.com that you can look into, but essentially youth are involved throughout the entire company. So it's not just with the product, it's also with the content. They're involved in our research, they're involved in our commercialization strategies. I'm the CEO of the company, but I actually work with the kids on a daily basis and I'm constantly texting them on Slack. So instead of just siloing them into product and kind of one co-design area, we really involve youth throughout the entire company and they're core to what we do. And that's been incredibly helpful in our engagement rates.
All right. And then we have another question. Aja asked, can you explain a bit about the role of the school? Do they help to push utilization or do you just recruit from schools?
So when we work with the schools in this particular study, we actually trained the teachers in the beginning of the year on the app, how it worked, and then we told them to implement this however they saw fit. So there were 3 different school sites, and they all implemented it in different ways, which was interesting. We did that on purpose because we wanted to look at real-world usage patterns. So we had all of the teachers across the sites kind of bring up the Neolth app, show the students how to use it. They got free access through their school emails. But at some schools, the teachers just said, you can use this at home however you see fit. And at other schools, we actually had the teachers creating like a Wellness Wednesday and kind of bringing this more into the classroom. So there was diversity in the rollout across the school sites, but I would say historically what we found is the more involved that the schools can be and the teachers in the implementation of the program, the more that can influence the long-term engagement.
And then Christine's asking, how are youth being compensated for their contributions?
In this particular study, this was a study that we did in partnership with the University of Miami. So any youth who participated in this went through the kind of assent and the parental consent process. And then there was also some monetary compensation as well for youth who completed additional research documents with the University of Miami. And the full details about all of that are going to be published in a longer manuscript with the University of Miami.
And then let me take a look. It looks like there are a couple additional questions. So as a follow-up for being compensated, Christine also are asking, I'm curious about the students who are supporting the product, go to market, etc. as well.
Yeah, happy to answer those questions. Do we have time now, or do you want me to answer that in the chat?
We have a little bit of time.
So it depends a little bit on the type of the student and the way that they're interacting with the company. We've had over 600 students work with us at the company, so there are kind of various different ways it works. Sometimes they go through their universities or their schools, they're getting college credit, or they're getting paid through the university. So that's one way that we found to be very successful. Happy to give more details about that in the chat.
Yeah, and we know this is definitely a very fascinating presentation, and I think all of us here are very interested in looking at how we can implement different mental health apps and just different interventions and solutions, especially with youth. So in the interest of time, I know we have one more question that Kristen asked about parents' involvement. If we can take that on chat, or we can circle back after all the presentations are done, I think that will be great. So with that said, thank you so much, Katherine. Would definitely love to learn more about the product and your study.
Thanks so much. Happy to answer those questions in the chat.
All right, next up, we have Myra, who will be talking about user-centered design and acceptability study, attitudes toward a novel app for medical student mental health.
Let me just give me 1 second to share my screen and then we'll get started. Okay, can you see that?
Yes, we can.
Perfect. Awesome. So my name is Myra. I'm a research assistant at Northwell, and I'll be presenting some findings from our HappyMed study. So our team was interested in assessing the acceptability and feasibility of developing a mental health app tailored to the needs of med students. And there were 3 main things that we kind of wanted to understand. Firstly, what are the most common stressors or concerns that these students are facing? Second, how are they currently accessing treatment, whether that be digital or traditional? And what are their attitudes towards the development of a customized app like this? So we did this by distributing a 19-question REDCap survey across 19 med schools in the US. And we recruited volunteers at each school to send out the survey to their student body listservs or GroupMe. And in total, 602 med students actually completed the survey. So we found that students reported high rates of uncertainty about the future and burnout, and students were largely unfamiliar with using digital mental health tools. As you can see in figure 1, they were pretty divided on whether they'd use a mental health app in general. However, almost 84% of respondents said they would be more likely to use an app if it was tailored to their needs. So that kind of brought us to the line of questioning of like what features would they like to see and the barriers. So the features they'd like to see were integrated habit trackers and productivity tools. And the most common barrier that was coming up was cost concerns and privacy, both just in general and privacy, like data privacy from their institutions. So based on our results, we believe that med students have an overall favorable attitude toward the development of such an app, and an app like this can effectively address the challenges that they face in accessing care.
Thank you, Myra. All right, we have actually quite a little bit of time to take questions. So any questions for Myra? Okay, I think I can start us off. A couple people might still be looking over the chat since we just got an answer from Katherine for the previous question. So I'm curious, when after you looked at all the different, I guess, needs or things that users wanted to see in the apps, what was something that you thought was the most surprising to see or to hear?
Yeah, so I think for me personally, one of the most surprising thing was a lot of students weren't a fan of like discussion boards or the community aspect of things. Reason why it was surprising is we did a second study, but that was with providers that deal with med students as patients, and talking with providers, they actually thought like some sort of digital peer support group would be really helpful for students, but the students themselves weren't really a fan of that idea.
Got it. And I think for medical students especially, I think there is a kind of idea of they're always busy, they're always doing something. How do you see this app and based on what they're saying in terms of how likely they will be using a mobile app and how that all will fit into their schedule? I wonder if you got a sense of that in your study.
Yeah, so that's definitely a big kind of concern that we'll have to kind of go through when we get into like the app development stage. So ideally, like that, for example, like we have a section that's like modules. So those would be kind of micro modules that people can do very quickly in a couple of minutes if they're like dealing with a very specific stressor. So kind of like tailoring the apps, like modules themselves as to like something very quick you can access. So it wouldn't feel like you're adding too much to your daily routine.
Thank you. And
Thank you so
then
much.
we have a couple questions from Christian. First is what was the breakdown of your students in terms of year of study?
Okay. So actually, if you scan the QR code once you guys have time, we do have a full breakdown of the demographics, but it is mainly first and fourth year med students, but we do have a relatively good kind of spread of like students from all 4 years, including people that are taking their research year.
And then a follow-up question to that was when was the data collected? Was it pre-COVID, during COVID, post-COVID? And I can imagine that potentially could make a difference or not.
Yeah, so this is actually post-COVID. We started data collection around last year in like October, November, and we just finished up back in April. So it's very, very recent.
Thank you, Myra. Is there any additional question? I think we have time for one more before we move on to our next presenter. Oh, I think we have. Oh, no, I think we're good. Okay. So let's see. I don't actually think I see our next presenter here. Let's take a look. Okay. It looks like the presenter has a little bit of mix up with the time zone difference. So while I figured that, oh, just kidding. She joined. Perfect timing, Arien. We are just going to your presentation. Let me know if you need a couple of minutes to settle in or if you're good to go.
Hello. Yeah, I need a couple of minutes to settle in. So,
Okay. In that case, Aggie, do you mind going first?
Yeah, I don't mind at all. I can go ahead.
Okay, perfect. So instead of Marine's presentation, we're going to go with Aggie's first, which is on human-centered design of a digital adaptation of a peer-led dissonant-based intervention to reduce fat phobia and anti-fat bias.
Cool, thank you. So hi everyone, my name's Aggie. I'm a first-year clinical psych PhD student at the University of Wisconsin-Madison, and I'm really excited to be here today to present on this topic. So we know that eating disorders are really serious mental disorders and are associated with many negative health outcomes. Eating disorders are very common on college campuses, but less than 20% of college students who screen positive for an eating disorder ever receive treatment. So that's really problematic. The Body Advocacy Movement, or BAM, is a peer-led, group-based, dissonance-based and eating disorder prevention program that has been found to reduce fat phobia, thin ideal internalization, anti-fat bias, and eating disorder psychopathology. So this is a really promising intervention, but it only operates at one university currently. So the goal of this project is to develop a digital adaptation of BAM using a human-centered design approach, which really would centralize the people who will be using or impacted by the intervention. In this case, it would be college students. So for this study, I interviewed 14 past BAM participants and 14 college students. From the past BAM participants, I was really able to hear what they liked and disliked about the intervention, feedback they had for adapting it to a digital format. I also heard about their experiences with anti-fat bias and fat phobia, mental health treatment experiences, and their thoughts on a digital adaptation of BAM. So each participant also gave me feedback on the 5 digital adaptation ideas that our study team had developed. So the first was just to have like a completely asynchronous version of the intervention, being on like some sort of app or other online platform. The second idea was to have this asynchronous version paired with peer facilitator support, either via like weekly messaging or like a one-on-one meeting with a peer facilitator. The third idea was to have the asynchronous intervention with a group discussion board. So adding the group back into the mix, getting that sense of community and also opportunity for reflection. The fourth idea was to have a mix of asynchronous content with short synchronous Zoom meetings, again, to facilitate the connection building. And then the last idea was just to have the BAM in-person intervention, but adapt it to a completely Zoom format. We found that participants preferred the mix of asynchronous and synchronous version. And yeah, they expressed the highest interest in that as well. Some other interesting findings, we found that 100% of college students with elevated eating disorder pathology had experienced fat phobia and anti-fat bias. So that really like underscores a need for an intervention like this, which is reducing anti-fat bias and fat phobia. Additionally, 75% of all the participants had used some sort of a digital mental health intervention in the past, which I thought was kind of interesting and speaks to like the growing use of these interventions in general. And then 71% of college students with elevated eating disorder pathology had an experience of wanting some sort of mental health treatment and not receiving it, which again highlights the need for these digital mental health interventions, which have like are uniquely poised to reach people who might otherwise be unable to access treatment. So next steps, we will be doing thematic analysis of these interviews because I have not done that yet. And then based on the feedback from the interviews, we will adapt BAM to a digital format for usability and pilot testing.
Thank you, Aggie. I, for one, am very excited to see what you learned from all the interviews. So maybe either the next STMH meeting or maybe even a manuscript. We'll definitely be watching out for that. Any questions for Aggie? Not quite a question, but Christine is saying that, wow, awesome. Thank you. This is very interesting.
Thanks, Christine.
Any breakdowns by gender, sexual orientation?
We definitely have that. I cannot say I've like really looked into it, but based on like my first glance, there is good diversity, which is awesome. I was definitely aiming for that. So we tried to recruit through lots of different pathways, and I think we were successful, but I haven't like done the official breakdown yet.
Would you mind giving us a quick sneak peek just based on high level of what you think the interviews might give you in terms of findings?
Yeah, for sure. So a lot of people talked about like what I was saying before with the past BAM participants, what they liked and disliked about the intervention and ideas they had for adapting it to a digital format. So I think that's going to be really helpful in terms of like they really want the digital format to be like really interactive as possible. And there are some things that we do in the in-person intervention, like people responding quickly to comments that people make that are fat phobic or exemplify anti-fat bias. Like, how can we respond to those comments in the real world? That's something that a lot of the participants said was like super helpful. So that's something we're definitely going to try to incorporate somehow into the digital format. I also think, these college students who have talked about their experiences struggling with these anti-fat bias and fat phobia, giving them tools in the app to talk about that and address that will be really helpful too. But yeah, people have really emphasized like the engagement aspect, which we know is an ongoing struggle with digital mental health interventions. Like, how can we keep people engaged and like gamifying it and like having notifications enabled and stuff like that. People have talked about that as being potentially helpful. So we'll see.
Thank you. I have one more question, but I'm curious if there's any question from the audience. Okay, so my follow-up question is that I know scalability is always a challenge, but it's also something that we really want with mental health applications and digital adaptation of existing programs for different populations and different challenges. So I'm curious if you've thought about what that would look like for college students in terms of, for example, is it going to be for individual university? Is it going to be more like a, I guess, social media sort of thing where it's anybody can join?
Yeah, I think like ideally I would want it to be more like anyone can join and not specifically for, certain universities that like have expressed interest in this. I mean, I think like partnering with like university counseling centers and stuff like that could be a strategy for like disseminating it. But I also, at the end of the day, like I don't want this to only be for college students, right? Like I want like anyone who has interest in like participating in something like this to be able to access it. I just think that's like, a good target population for now. But I think spreading it through social media too could, have really widespread implications and could get a lot of people access to it, which would be awesome.
Thank you so much, Aggie. And if anyone is curious to learn more or have additional questions after this, Aggie's email is on the poster.
Thank you.
All right. And Maureen, are you ready?
Yes, I'll just
Okay.
share my screen.
Perfect. So next up we have Maureen. This is poster 3.5, Young Adults' Use of Multiple Technologies for Mental Health.
Can you see my screen?
We can. It would be, I think, helpful if we could make it just slightly bigger.
Yeah, I'm just going to change this into present. Is it better now?
Yes, perfect.
Okay, cool. So hi everyone, I'm Mehreen and I'm a second year PhD in informatics at UC Irvine. And I study how youth use technology to self-manage their mental health. I'm just trying to hide the floating meeting controls. Okay, so in this study, we are looking at how young adults, specifically ages 18 to 25 years old in the US, use multiple technology platforms to self-manage their mental well-being outside of the clinical context. And basically by we're seeking to understand like what are the factors that influence their choices when choosing which platform they want to go to when they're coping for their mental health during stressful situations. And by exploring these motivations, we aim to contribute to the design of better mental health support systems for self-management. As I said, our participants were 16 young adults aged 18 to 25 who self-reported the usage of technology for mental health management and who also self-reported as feeling stressed, anxious, or depressed in the past month at least when we were recruiting those participants. And for our methods, we used semi-structured interviews. And we during those interviews, we talked about the kinds of stressful situations that the participants were experiencing and what platforms do they go to in their routine for if they feel stressed. What are their thoughts behind going to those platforms? Like, why are they choosing that platform instead of another platform, maybe? And what do they do on those platforms? And during our analysis, we used like an inductive approach for analysis. We also mapped some of the most common coping strategies that came up in our data to a psychological coping model from the psychological literature. We based it on, there's a model called the COPE, brief coping model. We based our coping strategies on that. Like we mapped what the participants were doing to coping strategies from the model. And our interviews were 60 to 120 minutes long and they were conducted via Zoom remotely. So in our findings, we found some interesting things. So first of all, we noticed that there was like a process going on for self-management. For example, like a stressful event occurred and then participants went and they chose a coping goal for themselves before they chose a tool, that where do I want to go and cope. So before choosing that tool, they chose a coping goal. And there were 3 coping goals that the participants mainly chose from. It was distractions, which were basically activities that help take their mind off stress, such as browsing social media, gaming, or just listening to music. Versus there was also information seeking, which was seeking advice and information to address stressors. This could be either information from people like on social media, or it was also information sometimes from search engines. And like sometimes it was more like subjective experiences from people versus other times it was more like objective information, factual experiences. And the third one was social support. This was like when participants went to other people, which could be their friends, family, or like strangers on the internet for emotional and instrumental support through social connections. So participants chose a coping goal, and then based on that coping goal, they went and chose a coping tool. So first, I'm going to know that, oh, I'm going to distract myself because I'm stressed, and then I'm going to decide if I'm going to go to maybe Instagram or TikTok to cope. So this was like the main chunk of our findings, like how are participants choosing between the coping tools. So we found out that participants consider different factors when they're choosing the tool, and we call them affordances of the technology. So the first affordance that we found was that participants looked at the tone of the coping tool, which is basically the emotional impact of the tool. So if I want, like, if I'm seeking distraction and I want lighthearted content, I'm going to go to a platform where there's lighthearted content for me. Versus if I want comfort, if I want the feeling of comfort, I'm going to a platform that's going to offer me content that makes me feel comfortable, reminds me of home. So we call that emotional aspect of the content tone. So participants like go to tools based on their tones. They also go to tools based on the level of engagement those tools offer. So for the level of engagement, there was participants looked at how much the content was stimulating for them, and like what was the duration of engagement. Did they want like instant distractions, versus did they want to go for like longer videos, like watch movies or something. So depending on the duration of the coping, that's how they chose the tool. And then there was also
Maureen, if I could stop you just 1 second.
yeah.
Yes, so we technically have a little bit more time. And the a lot of time is up, but because of
Mhm.
a presenter sending in a recording, we have a little more room to spare. I just wanted to make sure if our last presenter is here or not, and then we can resume.
Yes, sure.
Let me see. It's this. Oh boy. Illy? YLY? Or their co-author, Rita? Okay, I will take that as a no. But that poster would have been on enhancing chronic pain management, the crucial role of therapeutic personalization in virtual reality intervention. And since they're not here, I mean, if you could finish your thought, and then maybe we can give the audience a chance to ask some questions.
Yes. Yeah, I'll just wrap it up quickly. So, yeah, the third affordance that we looked at was how much people are interacting, like the depth of social interaction. Like, do I want lighthearted conversations with people versus do I want to go and went out about my stressor in depth? And the last affordance was they wanted to go to platforms that met their specific informational content needs, such as credible content. Versus going to platforms for like subjective experiences or objective information. And then like once they chose their tool, participants performed the coping and they were either successful in achieving their goal or sometimes they failed, and then they went back and chose a different coping tool, or they chose like a different coping approach. And yeah, right now we're like in the process of writing a paper for this study and we finished analyzing the data. Um, yeah, I think that's all. Any questions?
Thank you. Any questions from the audience? Again, you can use the chat or you can unmute yourself to ask questions to Maureen. I think I can start us off. So you looked at multiple technologies and different platforms, and it seems like you were able to find that depending on what they were looking for, they would go to different platforms. What were some of those examples? Or do you have any example of the platforms that they talked about? And on top of that, curious if you see any sort of correlation, just high level between goal and the platform that they would go to.
Yeah, that's a nice question. So, there was sometimes like correlation between the goal and the tool that they were going to, but because most people were using social media and social media is not like really designed for this purpose, and there's a lot of stuff you can go and do on social media. So, there wasn't like a clear correlation, but for example, if I want to like seek information, I could go to like Instagram and maybe I follow people who post information versus if I want to distract myself, I could still go to Instagram because there are reels that are like interesting for me and like distract me. So a lot of the times there wasn't like a direct correlation, but we did notice that people had allocated specific platforms for specific types of coping. So for example, people had curated their content on platforms. So there was like a participant who just went to Instagram for like if they wanted information about politics and stuff. And that helped their mental health because it made them feel like knowledgeable about politics, and that kind of boosted their confidence. Versus they would never go to like Instagram for distraction, because if they were stressed out and they needed like distractions in the moment and they would go to Instagram, the political videos would stress them out further. So they knew that this isn't the platform I want to go to. So instead they would go to like YouTube, which they had like specifically curated just for lighthearted content by liking funny pictures over the years, like interacting with such content. So that's like the level of correlation that we saw. But there were also participants who used like one platform for multiple kinds of coping, if that answers your question.
Yes, absolutely. Thank you. Any other questions from the audience? Okay, and I know we are almost at time, and I'll take the lack of question as Maureen gave a very detailed presentation for us. So a lot of the answers, or a lot of the questions that I had were answered during the presentation. And if anyone is interested in reaching out to her and learning more about this study, feel
I
free to
don't have
utilize
the
the.
email on this slide. I can just send it in the chat.
Yeah, I think that would be great. Alternatively, I was also going to suggest utilizing the conference Zoom events. We have a chat function, and we also have a people tab where you can find each other. And I also strongly encourage everyone to attend the networking sessions later today. And feel free to utilize some of the breaks that we have to find each other and chat. Other than that, I believe that is all the presentations that we have for this particular session. If anyone have any questions, I will be here for a couple more minutes. Otherwise, enjoy your break, and thank you so much for all the presenters and everyone for attending.